Good afternoon. Haven't done that in a while. My name is Tony Peebles, a past president of the City Club and current president of the City Club Forum Foundation. Welcome. I have the privilege of introducing our speaker today, Mr. Thomas J. Strauss, PharmD, is the president and CEO of Summa Health System here in Ohio. Prior to joining Summa in 1999, he was president of the Meridia Health Services here in Cleveland. For 10 years, Strauss had a number of leadership positions with Meridia, including the leadership for the system, 8 service lines, president of the Eastern Region, president of Meridia South Point Hospital, president of Meridia Suburban Hospital, and president of Meridia Institute Meridia Health Ventures. He is also experienced in private industry, having held positions with Baxter Health Corporation prior to his tenure with Meridia. The positions he held in Baxter included president of Caremark Home Care, zone director for Travacare Home Therapy, and other positions. He is a pharmacist by trade. He was the assistant director of patient care modules at Allegheny General Hospital prior to joining Baxter in 1983. Mr. Strauss earned his Doctor of Pharmacy degree from Duquesne University in 1978, and he completed his residency in pharmacology at Mercy Hospital. He is a member of the Akron Regional Hospital Association, the Akron Chamber of Commerce, the Cleveland Health Network, the United Way of Summit County, Akron Tomorrow, the Ohio Hospital Association CEO Committee on Advocacy and Public Policy. He has a strong focus and published many articles and given talks in the areas of servant leadership, patient-first philosophy, accountable care organizations, and, of course, healthcare reform. He and his wife, Susan, have 3 sons. Please welcome Thomas J. Strauss.
Thanks, Tony. It's great to be back up here in Cleveland. I got to understand, it sounds like my time at Meridia, I couldn't hold a job. Well, scary. I do want to take a moment to recognize someone in the crowd as part of the Summa family, and that's Ohio Senator Frank LaRose. Where is Senator LaRose? It's good to have you here. Welcome. It's good to have you. And I have to say that I've been in healthcare now 37 years. And you heard I had 10 up here in Cleveland with Meridia and then the Cleveland Clinic Health System, and now my last 13 down at Summa. And I've never enjoyed my work more than right now, which I think about the culture of care we deliver, which talks about the way we care for patients, but the way we care for each other. And I think it's a really important time. And I've never, in my 37 years, seen a time of change like Sister and I are about to see here in healthcare in this country. And let me harken back. In the fall of 2008, the auto industry, which was a cornerstone of our region's economy and of our nation's history, was on the brink of collapse. Many of us wondered how this could have happened. We wondered how this industry that had essentially defined the United States through the 20th century could have so colossally failed to adapt to a changing 21st century. And in fact, it took this seismic shift, a fundamental re-envisioning of the business, and billions of dollars of government money to bring the auto industry back from the edge. And today, of course, the industry is once again thriving. Here in the Midwest, the auto industry is creating jobs and prosperity for our families and getting back to the business of building the cars that Americans love and that the world wants to buy. The auto crisis was fundamentally a crisis of leadership, a failure to recognize change and to search for opportunities in a changing business environment. And what's here today in healthcare, what's really scary is that many in healthcare today are doing the exact same thing, making the exact same mistakes, and quite frankly, hoping for Congress to metaphorically at least bail them out. So a change or a failure to change, I believe, will lead to a failure in our industry. And our national conversation about healthcare today is dominated by speculation as to the fate of healthcare reform. Is the landmark health reform law the right policy prescription, and will the Supreme Court even uphold it? Now, these are important questions, and they deserve our attention, but in my job, I can't let them monopolize my attention. Because if we wait, for laws and decrees to be passed on to us, if we do nothing until we get answers from somebody else, if we refuse to change until we're left with no alternative, then I believe we will miss a major opportunity. An opportunity to reinvent the health system to one that we know can work. Now, hopefully everybody in this room recognizes that the way we finance and deliver health care in America is unsustainable. I have to tell you that 7 in 10 adults in a recent survey said that adults believe that U.S. health system needs fundamental change. And unlike the auto industry, the alternative for the healthcare industry in Ohio and America isn't collapse, it's worse. We call death by 1,000 cuts, or in our vernacular, death by 1,000 payment cuts. Now, given this reality, there's one thing I think we all can agree on, and that's the need for reform. Let's look at some of the numbers, both in human and economic terms. Today, over 50 million people are uninsured. That's about almost 17% of the population. Medical bills are now causing more than 60% of personal bankruptcies. And at the same time, we're spending $2.5 trillion on health care every year, 17.6% of our GDP. And with spending and insurance premiums rising faster than wages, inflation, and overall economic growth, crowding out other really important priorities. In fact, the family health care premium today for a family now exceeds what a minimum wage worker will make in a year. And if you look forward, our unfunded Medicare obligations, our unfunded Medicare spending in the future alone is now $35 trillion. And that's more than double the entire United States GDP. And yet, in the face of this, we have a population that is getting less healthy by the day, and a healthcare system that, despite the amount of money we spend, doesn't have the outcomes that measure up with many other industrialized nations. Now, clearly, I don't think we can wait for reform to accomplish the necessary change, but reform has been enacted, and so I think it's really important to understand what it's about. And as an aside, it's really revealing that according to a recent poll, 47% of Americans disapprove of the health reform law. But 6 out of 10 say they don't have any idea how the law will affect them. I have to say it sounds a little bit like sometimes in error, but never in doubt. But in all seriousness, it indicates that there's a lot of misunderstanding about what the law is about. So I'm going to walk you through that briefly. The law has 3 primary goals. First goal is affordable health insurance for all. Second is a reduction in health care costs. And third is improvement in the quality of care. Sounds pretty reasonable. So to achieve the first goal of affordable quality health insurance for all, the law does several things. First of all, it prohibits insurance companies from denying coverage to people with pre-existing conditions. And it prohibits differentiated rates based on things like gender. The law also requires insurance companies to offer a minimum amount of coverage and to spend less of their premium revenue on administrative costs, profitability, or shareholder dividend, and more on medical care. And I'll tell you, or if they don't meet a certain level, they have to issue rebates back to their enrollees. So this final piece is something called the medical loss ratio. And it requires every insurance company to spend anywhere from 80 to 85% of their premium on care. Now think of that. In fact, it's significant because a study released just last week by the Commonwealth Fund showed that had the law been enacted in 2010, these insurance companies would have had to rebate $2 billion to their enrollees in that year. 53% of the individual insurance market and 23% of the private insurance market would have had to have gotten rebates based on that statistic. Now, at Summa, we have about 225,000 lives with our affiliated health plan, SummaCare. So you can see these changes, if sustained, will certainly alter our model that we look for in the future as well for all health insurers. So to make sure that these requirements work and to balance the risk profile of insurance pools and to prevent people from trying to buy insurance only after they get sick, the law requires almost everybody to purchase insurance up front. And those that can't afford it will be given subsidies. And the very poor will actually have expanded access to Medicaid. Younger people are now able to stay on their parents' health insurance up until age 26. To achieve the second goal of reducing costs, the law reforms the way hospitals and doctors are paid so that instead of being rewarded for the quantity of care they provide, we will be rewarded for the quality and coordination of that care. And so we call ourselves a healthcare system in this country, but as a hospital, we only get paid when we treat sick patients. So we have a good flu season, the beds are full, and we make a lot of money. Isn't there something wrong with that picture? So we're going to start to change that. To achieve the third goal, and that is improving quality, the law includes a range of pilot programs to test different ways to help people get healthier and stay healthier. And that's what we're going to talk about today. There's something called an accountable care organization. And the idea is to identify best practices and spread what works. So here in Ohio, we're already starting to see the impact of this Affordable Care Act. Let me give you some numbers. As of June of 2011, 82,000 young adults in Ohio now have health insurance coverage. The law bans insurance companies from imposing lifetime dollar limits on health benefits, which is important to people who suffer from terrible diseases like cancer that can bankrupt families. Over 4 million Ohio residents no longer have to worry about these lifetime limits in coverage. It also has established a special plan to immediately cover people who cannot get health insurance because of the pre-existing conditions. So they don't have to wait till that part of the law is enacted in 2014. And when the full insurance reforms will kick in then. And now over 2,000 Ohioans have already signed up for the plan. So as you know, within the last few weeks, the Supreme Court heard arguments challenging whether the government can require people to purchase health insurance, whether the law can stand without that individual mandate, and whether the expansion of Medicaid imposes an unfair burden on the states. At the same time, Representative Paul Ryan, chairman of the House Budget Committee, has released a proposed budget that would, among other things, transform Medicare to a program under which individual seniors would be responsible for purchasing their own plan, and that's called a premium support plan. So pundits and policymakers are speculating about the outcome of the Supreme Court case. They're wondering if the Ryan proposal will prevail. But here's the thing for me. The discussions about reform, whether we're talking about the president's health care law or the Ryan plan, and the angst about those changes comes down to three things. Who's going to pay? How much will be paid? And what form will that payment take? But none of that changes the reality as a hospital system. No matter who pays, no matter how they pay, we must do a better job of coordinating and delivering quality care. And it's truly that simple. If we do these things, we succeed under any model, regardless of legislative or judicial outcomes. And as I said earlier, healthcare cost trajectory could arguably be justifiable if we are seeing dramatic improved population health, but we're not. So regardless of what Congress does, even what the Supreme Court decides, those of us in the business of providing health care have a clear decision, and that decision is to not to accept the status quo. We have a window of an opportunity to make the kind of changes that I think are going to be needed to improve the health of populations. Now, you know a little bit about Summa. We're one of Ohio's largest integrated healthcare delivery systems. We have 8 hospitals, multiple community health centers across 5 counties. We provide more than $100 million a year in community benefit, including charitable and subsidized care. And I will tell you that in Summa County, we get no help from our county. Up here in Cuyahoga County, you have Metro Health Medical Center. They have a tax levy that gives them about $35 million a year to support their charity care. We get zero. We're also the largest employer in our service area, now with 11,000 employees, and we represent about 275 employed physicians in a multi-specialty group. Overall, Summa is now $1.6 billion in revenue, and we generate $2.86 billion in total economic impact for Ohio. But what distinguishes us from other large health systems is that we also have Ohio's highest rated healthcare plan, and that's SummaCare. SummaCare was formed in the 1990s as an option for large self-funded employers in Akron like Goodyear. In fact, we were established to help Goodyear with their employee health. Today, we cover more than 225,000 lives in Northeast Ohio, as well as Vermont, Tennessee, and Florida. And SummaCare has afforded us more than 20 years of experience and insight into healthcare integration. And within our reach, we can make the changes that fundamentally will shift healthcare in Ohio, and that's what we're trying to do. We want to make the kind of improvements that will inspire others to follow suit. So if we look at the way we deliver healthcare today, compare it to this new accountable care model. I love this description. Jerry Penso, the medical director at Sharp in San Diego, compares accountable care to a car dealership. And he says that in our fragmented health system today, patients typically go to different doctors for different problems and pay each one separately. And he compares this to seeing a different mechanic for each problem in your car. Someone for steering, someone else for brakes, and another for tune-up. But as car owners, we don't do it that way. Most time we go to the dealership and get all the repairs taken care of in one place. You know, healthcare needs to be as coordinated as the parts of the human body itself, and that's what accountable care is about. At Summa, we have a long-standing commitment to integrated healthcare delivery, and we're not waiting for the government to push us towards this model. We're already embracing it. Last year, we launched an accountable care organization, or ACO, in partnership with a large number of physicians in our community. And in fact, the goal of an ACO is to reduce the total cost of care for a given population while maintaining and improving the quality and satisfaction of that care. And an ACO is responsible for managing clinical care and clinical integration, capturing data across the continuum of that care, both inpatient and outpatient, measuring and monitoring costs and quality, and coordinating financial relationships. So it includes primary care physicians through what's called a medical home model. It also looks at hospital specialists and should be able to administer payments, set benchmark, measure performance, and distribute shared savings. And what makes our partnership unique is that we are working with independent physicians in our community. That ACO is called New Health Collaborative, and more than 450 employed and independent physicians are now members, each with a vested interest in our ACO's success. So they are improving quality, improving safety, and creating higher value. Value that they ultimately share in through shared savings. It's incredibly satisfying for these patients and these physicians because they're delivering the right care at the right place, at the right time for the right patient, but at the right cost. We also wanted the ACO to be physician-led from the beginning. So 7 of our 9 board members of the New Health Collaborative are physicians. And approximately 12,000 of our SummaCare Medicare Advantage members are now benefiting from this program. And while it's too early to say that the full impact will be, the results so far have been encouraging. In our first full year on these 12,000 lives that we have with Medicare Advantage, we've seen an improvement in both quality and safety, but a decrease in cost. In fact, we saw a 7% reduction in our projected budget of cost of care for that total population health for those patients and those enrollees. Our readmission rate after 30 days from discharge from the hospital for cardiac heart failure patients was only 10%, less than half the national average of 24%. So think about what this would mean and to extend these results throughout the nation, tens of billions of dollars of savings just through this little bit of a focus that we've had this year. These improvements are the direct result of team-based coordinated approach to care. And based on this success, we're applying for inclusion in a new federal Medicare shared savings program. And if selected, we hope to add more than 30,000 new Medicare members in our community. In the meantime, we're also moving forward with an extended ACO population that includes our employees, so probably 7,000 of our 11,000 employees. And we're partnering with Premier. Premier is a national cutting-edge healthcare innovation company, and we're in a collaborative now with 20 other health systems around the country, places like Geisinger and Danville, PA, Presbyterian in Albuquerque, Intermountain in Utah, to learn from each other and create the prototype development around this accountable care organization. One of the further benefits we've generated through Summa Care is considerable experience in managing chronic disease and promoting the overall health of populations. And we've been recognized for providing outstanding quality while maintaining low cost than comparable systems. And you know the statistic. 1% of our population in this country now generates 22% of the total health care costs. 5% represents 50% of costs in healthcare today. So it's critical to manage these chronic disease populations in the future. So the future imperative that we manage the overall health of our entire population aligns well with our experience. And we're willing to share that experience. Already, a number of other hospitals and health systems around the country have come to Summa and Summa Care to learn more about this integrated model we've built around managing population health. To further service this need, we're leveraging our tools and best practices to create what's called a population health toolbox, a set of products and services that will enable other health systems around the country to build and manage their own ACOs. We're eager to share our experience, our nationally recognized disease management, and patient engagement programs. So I want to close now with telling you, what does success look like when quality care is coordinated and patient-centered? It looks a lot like a new center we just created called the Center for Health Equity. It's a brand new development in the Worcester-Hawkins neighborhood of West Akron. And if you don't know where this is, Worcester-Hawkins is a predominantly African-American neighborhood whose residents have long been medically underserved. And the Center for Health Equity is part of a larger development called the Village at New Seasons, the result of an incredible collaboration between Summa Health System, Testa Builders, and the House of the Lord, a church with more than 7,000 members in West Akron, again, mostly African American, mostly underserved. Several years ago, the pastor, Bishop Joey Johnson, acquired a large parcel of land that housed a deserted shopping plaza that sat vacant for years. And he approached Summa to help him develop it. Today, that blighted piece of land has blossomed into an $11 million complex with retail, affordable housing for senior citizens, and a 10,000 square foot healthcare center. But the goal was more than just to establish a healthcare facility in an underserved area. We engaged community groups, neighborhood advocates, developers, investors, and others to create an environment in which we could really learn more about the causes of health disparities and then fight them. Our center includes what you would consider to be traditional, exam rooms, procedure rooms, and the like, but it goes further than that, traditional to try to reach people where they are. For an example, we found that patients were complying with their dietary care because they felt like they were losing control, giving up things like their favorite meals. So we decided to build a demonstration kitchen to teach people about nutrition, to offer cooking classes, and to show patients how their favorite foods can be incorporated into their dietary plan. And we have a community room where we can talk about exercise and healthy lifestyles. And one of our doctors who staffs the center, Dr. Teresa Myers, is passionate about caring for these vulnerable patients and making a difference in their lives. Dr. Myers has her own remarkable story. She grew up in Huff, the Huff neighborhood here in Cleveland, a very poor neighborhood, many of you know. And what's amazing is she herself has overcome incredible odds to become a physician. And now she's helping her patient overcome those odds. She tells the story of one patient who was diabetic, obese, struggling with her health. The patient refused to take her oral medication. She refused to try insulin. And she said that the diabetic education class had been useless. How's that sound? So Dr. Myers knew that she had to engage the patient in her own care. So Dr. Myers bared her soul to this patient, telling her, "Nothing makes me sadder than to see you not feel well. I live to see you well. I wait for the day for you to come to me to say you are better. Let's work together and get you well." And they did. The patient agreed to meet with Dr. Myers and a dietitian at the clinic to map out a new approach. They came up with a plan together, and the patient felt empowered. And when she saw a little success, that motivated her to keep going. And now that patient has lost weight, her diabetes is under control, and her outlook in life has improved dramatically. And as Dr. Myers said, that is the transformation of an inactive participant to someone who is totally engaged in her own health and well-being. The physician working with the dietitian in a facility with a demonstration kitchen, this is the care that people need. And increasingly, this is the care that payers reward. This is the type of care that gets results and save costs, but most importantly, it's the type of care that people need to live longer and to live better. By providing targeted services in the community, we expect to decrease visits to the emergency department, lower hospital admissions or the length of stay for those that need to be admitted, and reduce the severity of illness, including complications of these chronic diseases. And there is so much more to be done. But we at Summa are optimistic that we're on the right path and on an important journey. From Blockbuster Video to Borders to Kodak, we've seen what happens when companies fail to adapt to their changing circumstances. But right here in Ohio, we've also seen what can happen when they do adapt. When they are willing to make the tough choices, the tough changes necessary to survive in a rapidly changing world. You know, just about an hour's drive southeast from here is Lordstown, Ohio. During the height of the auto crisis, plants like the Lordstown Assembly were down to just one shift a day. Tens of thousands of auto workers from Ohio had lost their jobs, and the plant itself became a symbol of all that had gone terribly wrong. But GM was willing to invest in changing that factory at Lordstown, and it worked, refitting it to build vehicles with smaller but more efficient engines. And today, that factory isn't just surviving, it is thriving, building the Chevy Cruze and meeting worldwide demand for safe, highly efficient vehicles. In fact, they're now operating with 4,500 workers on 3 full shifts a day. But just as the auto industry is once again succeeding in Ohio, with 16,000 new jobs and the promise of continued growth, if we in healthcare can innovate and reinvent ourselves, we can similarly succeed with a much less painful transition. And I have to tell you, we have more at stake because healthcare is a much larger part of our economy in Ohio than automaking. In fact, just in hospitals alone across our state, more than 300,000 individuals are employed. So, can we cut through the political rancor and partisan debates? Can we go even further than the laws and the statutes will take us and take ownership over our own destiny and make the changes we know we need to make? As the CEO of Summa and as a proud Ohioan, I believe we can. I believe we must, and I believe we will, and I believe when we do, when we embrace this incredible opportunity to build something new, a system that strives to provide the entire population of our communities with better care, at better cost, with better outcomes, then we won't just be improving the lives of our fellow Americans and fellow Ohioans, we will be a model for the nation. So thank you.
Today at the City Club of Cleveland, we've been listening to a Friday forum featuring Mr. Thomas J. Strauss, President and CEO of Summa Health System. We will return to our speaker momentarily for our traditional City Club questions and answers. Please formulate your questions now and remember to be brief and to the point. We welcome all of you here and those listening to WCPN 90.3, WCLV, WTAM, or one of the many radio stations in our network across the country. Our television broadcast partners are WVIZ, PBS, IdeaStream. Television broadcasts of the City Club are made possible by Cleveland State University and PNC. Our live webcast is supported by the University of Akron. We would like to welcome guests today at tables hosted by Baker Hostetler, Charter One Bank, Kent State University, Medical Mutual, and Summa Health System. Thank you for your support. Now we would like to return to our speaker for our traditional City Club questions and answers period. We welcome questions from everyone, including guests. Holding the microphones today, our City Club Program Director, Carrie Miller, and our Special Initiatives Coordinator, Phil Williams. First question, please.
First question. It's over here. Mr. Strauss, you're terrific. You always have been and you always will be. But my question is this. I have two questions. One is, can you, under this new program, will you be able to choose your own doctor, which has been a concern of a lot of people? And the second thing is, I'm concerned about the education of the next generation of doctors. Will they want to enter this new life, because it used to be a very lucrative run for doctors, and will you get the best of the best to come forward and be doctors? That has not been mentioned in all of this. Thank you.
Thank you. It's great to see you. I would say that there's no question that part of this accountable care direction, and it's part of the law starting in basically 2012, allows patients free choice. They can go wherever they'd like to go. So yes, you can opt in and out. And I would say that for our future physician leaders, the beauty of what this does is allow, especially primary care physicians, these patient-centered medical homes, that builds out the capabilities and the support for our physicians, so they have a multidisciplinary approach to care. They have stronger support than they've ever had, which really gives them the focus of being able to work with the patients with more time and hopefully a broader type of support network. So as an example, the physicians, when they go home at night, now we'll instead of having a regular answering service, we'll have a call center staffed by nurses 24/7. And these nurses will have two screens, one with the patient's medical record, and the other side with the latest protocols of care, evidence-based practice protocols. So the physician, it will be seamless. When you call Dr. Jones after 5, you'll get someone to say, hello, this is Dr. Jones' office. You'll work through a whole triage of coordination of care and be able to get all the information to the patient that's needed to figure out whether they need to be hospitalized or what they need, and then the next morning have the physician with that full coordinative care and really give them the support they need. So we believe it actually will be more rewarding under this new model for most physicians.
Mr. Strauss, you mentioned at the very beginning of your talk that there are now 50 million Americans that do not have health insurance coverage, a truly staggering number. The Obama health care plan requires insurance, as you did mention, but assuming that the Supreme Court of the United States does declare that provision to be unconstitutional, which from all advanced reports seems quite likely, those 50 million people will still not have insurance. What can a company like yours do in the limited geographical area in which you function do to eliminate that and to make insurance coverage available to those people in your area who do not have it now?
Well, it's a great question. And first of all, I'm not about to weigh in on what the Supreme Court's going to do. But I do have concerns, because if you think about the health reform law, with 50 now, I think people estimate now it's almost 55 million people without health care coverage. And what's really frightening, that 8 out of 10 of these people come from working families. So these aren't people without jobs. So today, companies less than 200 employees, only 60% even give coverage to their workforce. And so one of the beauties of the plan, and you have to look at all the components, one is the individual mandate. The second one is to enforce employers to give coverage or pay a penalty, especially those employers greater than 50. Now, if the Supreme Court does call the individual mandate unconstitutional, Then there's other part of the law, the requirements on the insurance reform, with covering everyone regardless of their preconditions or lifetime limits. If you don't also, for the insurance companies, and I know my colleagues at Medical Mutual are in the room, then it's almost a death spiral because, as I said in my talk, people will elect not to get coverage and only get coverage at the period of time when they get sick. And the insurance company would have to insure them and have to reinsure them at a similar rate. We believe that could create the potential of a death spiral. And then really there's going to be we're not sure how it's going to be handled, but the statewide exchanges and an expansion of Medicaid are the belief of where we will go with that. For us, we provide, as you know, in hospitals, coverage regardless of people's ability to pay. So today, 1 in 4 of every patient that comes into our ER doesn't have health care coverage. We provide coverage regardless. That's up from 1 in 13 just a few years ago. So I don't have a good answer. I believe that it will cause an expansion of Medicare and Medicaid. I think there will be opportunities through the statewide exchanges for people to enroll in a lower cost insurance plan. But there is a lot of speculation what exactly will be retained if the individual mandate is continued or is decided to be unconstitutional. Probably wasn't the clearest answer, but that's, I think, where we are.
Mr. Strauss, would you describe a little more what an integrated health system means? You have both the care delivery part, the hospital, and the insurance part. Is there any financial relationship between the two? Are they totally separate? Or if you lower the costs in the hospital, does the insurance component benefit economically?
Well, we think that's a great question. Thank you. An integrated healthcare delivery system includes the hospitals, the physician component, and the insurance plan. And what makes us different is that we have this insurance plan now with 220,000 lives in our community, which is a fairly, significant chunk of business there. And so we believe that we already have this 20-year experience of population health and population management. And we believe in the future that's where it's going to move towards. So accountable care is getting us there. We do have a dynamic. They all sit under our parent. It is a bit challenging because Marty Hauser, our president of Summa Care, is here. His goal is to keep as many people out of that hospital as possible. And then we have our hospital executives that want to fill the hospital beds. So we are schizophrenic. I have a twitch that comes on periodically. But in truth, I've seen if you're only focused on filling your beds, if you're just a hospital system, you have no incentive to keep people healthy and out of the hospital. I saw it with my own father. My father had a whole host of chronic diseases, passed away about 1.5 years ago. At the end of his life, of 87 years old, he was at a hospital in Pittsburgh, so it's nobody here. They overtreated my father to the point where they shut down his kidneys. He barely survived that episode, and he had C. diff, which is a really terrible infection that causes severe diarrhea. He was starting to get better. We brought him back. He was at a nursing home close to the hospital, and I got a call one day that they wanted to take him in and give him a cardiac cath. He's 87 years old. What possible benefit could that be? So this whole idea of better coordinated care, eliminating the fragmentation, and aligning incentives to keep people healthy and out of the hospital, and then the very important piece of not only the chronic disease, but the end-of-life care. You know the percent of cost at the end of people's lives. We have to give them true palliative care review on the quality of life and what outcomes they will achieve with this continued overtreatment we do in the hospitals today. We estimate that about 30% of what we do in hospitals today may not be necessary. So if you think about spending $2.5 trillion, if we could take 15% of that out, there's more than enough money to turn this thing around. And so we got to align those incentives away from volume to value in population health.
Mr. Strauss, thank you for your comments today. With such a strong regional network of healthcare delivery, can you share some collaborations that are already in place that we might not know about, or collaborations you'd like to see in place in the near future?
Well, we love to talk about the collaboration we're getting in Akron, Ohio. So let me just tell you this, that we have what's called the Austin Bioinnovation Institute of Akron. In fact, my good colleague, Dr. Jay Gershon, president of our medical school, Neomed, is here. Jay, you want to raise your hands? Good to have Jay here. The beauty of this collaboration is we have all the hospitals in Akron, the University of Akron, Neomed, and we are basically innovating and collaborating around biopolymer science and orthopedic and wound healing. And our goal is to create innovation, commercialization, and new jobs. And by the way, collectively, along with the Knight Foundation and First Energy Corporation, we've invested $80 million over the first 5 years, with the potential to go to $200 million over 10, to create new commercialization jobs around biopolymer science, orthopedics, and wound healing. And Steve Schmidt, who is Chief Operating Officer of our foundation, is here, will tell you that prior to this collaboration, we maybe had 5 different invention disclosures at Summa Health System. Just within the last year, with this collaboration and innovation of harvesting these ideas, we have close to 60 just within the last year. And our belief is, through this collaboration and innovation, that we will create new opportunities for jobs in Ohio. Now, I have to tell you, we have great collaboration as well. University Hospitals Health System, we are now collaborating with them around their employee health plan. We're thrilled to say that in January of this year, we are providing some of the back office support for them and sharing best practices around their accountable care organization with each other. And you know, we've been partnered with the clinic through the Cleveland Health Network for many years. So despite what you read about all this competition, we do collaborate, and we find ways to make it work. And you know, I have to say the other thing, we are blessed to have wonderful health care in this region. I hope you know how blessed we truly are. And despite our competition, we have some of the best health care in this country by far.
Over here. It's a great talk, and it's clear, it's easy to see that things need to change, so it must feel good to do what you're doing. The question is, with regards to physicians and how they're paid right now per click and everything else, take the physicians who are already in practice, not the ones coming in, but have you met much resistance from them in making this change? And I guess the better question is, if so, how do you combat that? I mean, how do you get physicians who have been rewarded financially for doing more to embrace this, I guess?
Oh, it's easy. Well, obviously, you heard the statement, death by 1,000 cuts. I mean, that's basic. The pie is only so big. I mean, think about this. $2.5 trillion, 17.6% of the GDP. The next closest percent of GDP of any other industrialized nation is probably 9 or 10%. So how many business people in the room think this can be sustained? So they understand the future is not bright if you stay in that old way. You know, we talk about the 2 curves. The fee-for-service curve, which will just go down and you will get paid less and less and less, and you'll have to do more, and it's like being on a treadmill that continues to speed up. If you think about what we're going to transition to, true value-based purchasing, value-based care, you'll be able to expand the amount of patients that a physician can cover, because you'll have specialty nurses, you'll have group visits, and so you're engaging the patient in the activity, and the physicians see that the old way is just not sustainable and believe that if we do it correctly, that we will actually improve their quality of life and their focus. Now, some of them that are my age may be considering just getting the heck out, but many are excited about it. And if you lay out the vision for them and they understand where we're trying to go, it does make sense. It does make a ton of sense.
I think you said in certain circumstances 30% of the costs were arguably unnecessary. To what extent is defensive medicine or fear of legal consequences of not going the extra mile a factor there?
It's an absolute part of it, unfortunately, but you got to understand, so this patient-centered medical home with an electronic health record now embeds evidence-based practices in the medical record, both in the office for the physician and in the hospital. So it's actually easier for physicians now to practice the most appropriate care, evidence-based practice, than it's ever been before. And so when you invest in that, and when you have the kind of informatics that we're going to have to give them that data, and as long as they stay with the program, now they can always override. You know, we never want to take away a physician's right to do that. But we think in the end it'll cause less of that. And with the reform that we've had, some of the tort reform in the states worked pretty well. We have our own captive insurance, and that's had fabulous results. And we do a lot of risk management, risk development in our practices. So we think with embedding those practices both in their office and also connected through portal in the hospital. A physician today can sit at home, have full access to all their patients' records, be able to look at film, and be able to change the medications from home. And the last piece, just to talk about safety, we now have handheld barcode wands. We're just getting ready to implement this on the floor. So a nurse now, when they're ready to give a medication, will be able to wand the patient's wristband, wand the medication, and so it's a closed-loop system. It's almost fail-proof. Now, nothing's ever fail-proof. But give the right drug to the right patient at the right time at the right dose. And so those are the kind of things that we're seeing. So less, mismanagement of practice.
I saw an EOB this morning. $99 for a particular service was the charge. The amount allowed by Medicare was $11. Now, if the patient has no insurance, they get billed $99. If the hospital accepts insurance, they get paid $11. You mentioned at the top of your talk the number of uninsured who end up in bankruptcy because they can't pay the bills. If hospitals are accepting what Medicare and other insurance companies are paying, what can or should hospitals be doing now when they're dealing with the uninsured to keep these people out of bankruptcy?
Yeah, that's a great question. And let me say this, and I should have brought this up earlier. You got to understand the 50 million people that don't have coverage. As I said, when they come to the hospital, we provide the care. And by the way, any hospital system will work with that patient as long as we know there's an issue. We never charge them cost. We never charge them our list price. Right now, we realize about 35 cents on the dollar from what we bill to what we collect. 35 cents on the dollar. But you need to know that the cost of managing that charity care in hospitals today is $166 billion. And I'd like to think that $166 billion, guess who's paying for that? Those of you that have health insurance today through your employer, have commercial and coverage, are paying a hidden tax that nobody realizes is there. So when you talk about a tax, we estimate that tax is about $1,200 a year that you're spending extra to get your employer coverage to be able to pay the small amount of managed care companies pay us higher rates. So it's unfortunate that that's the case, and our goal is, I believe, with the individual mandate, to neutralize that. So that today, as I've said, Summa Health System spends 60, I almost said billions, not quite, $60 million a year of charity care and bad debt after care assurance. So after I get the help from the from the federal and state government, I still have to cover $60 million. When I have 62% of my revenue coming from Medicare and Medicaid, where I basically lose 14 cents on the dollar for every Medicaid, and I break even, I'm one of the few in the country that actually can come close to breaking even on Medicare. The only margin we're making today is on these managed care rates. So the whole thing is broken. The whole system is broken. So we have to neutralize that, I believe, with exchanges, with the individual mandate that gives us at least some coverage for every patient that wants to have coverage, and then eliminate this hidden tax that everybody in the room is paying for. But we will discount. Every health system in this country, I believe, will give a discount to somebody who's paying out of pocket. And that's part of what we do.
Thank you. Tom, thank you very much. And we're delighted with our 39-year relationship with Summa at NeoMed. One of the things you mentioned was the $2.5 trillion being spent on health care. And we all know that a third of that is due to obesity-related issues. So $800 billion a year spent on cardiovascular disease, stroke, diabetes, and so forth due to behavioral issues and things that we can control ourselves as individuals. Would you explain a little more about how ACOs, accountable care organizations, help with health and wellness issues and incentivize physicians to be involved with that, and incentivize patients to be healthier so they don't get the disease in the first place?
That's a great question. And I think you know that part of this thing with ACO, so for 12,000 patients, we get basically the full revenue reimbursement from those cases. So an example, 12,000 is about $100 million of revenue that we got to manage the total cost of care, whether they're in the hospital or not. So it's our goal to create these kind of wellness-focused, patient-centered medical home. And so it's the exact kind of thing we talked about in my story of the patient at our clinic. We have to surround them with people that they have group visits so they get engaged around their health, diabetes, with their diet, their exercise. We then have exercise programs, healthy lifestyle. So we have coaches, almost health coaches or care navigators to come alongside the physician to look at those activities for the patients. And we do everything we can to incent them. Now, there's no way we can incent them with dollars. But we do that, as an example, with our employee base. One of the things we've done this year at Summa as an employee is we are incenting our employee base to have better lifestyles for smoking, if they have a certain body mass index, cholesterol levels, etc. We will give them a discount on their employee health plan to activate them in their health. And we are seeing really nice results coming out of that. So it's part of the overall population health that we're going to be focused, that includes things like exercise, diet, health coaches. Those are some of the things that we're doing today.
Mr. Strauss, you didn't talk very much about the pharmaceutical companies and what the role is that they play in the cost of healthcare currently, and if there are reforms that are coming down the pike in the pharmaceutical industry.
Well, first of all, one of the key problems we have with patients with chronic disease is making sure they can have the medications they need to fight that disease. Because when people don't have coverage, one of the first things they give up is they said, I can't afford to do my medications, et cetera. So I think the pharmaceutical companies, obviously the use of generics are going to be critical for that. But in general, they're going to have a key role in this reform. I think reform also helps on, especially with Medicare patients, fill that donut hole for coverage of patients' medications. There's a gap between them, and that's starting to be closed with the reform piece. So I would think that one is finding ways to make sure that patients then get a chance to have their medication. Most of the pharmaceutical companies do have ways that if people don't have coverage, they can get samples, or there's other ways to get provided coverage, and then engaging them around generic drug distribution and trying to do as much as we can to decrease our costs there.
Tom, wonderful talk, as usual. I would like to ask about the reform of the payment system. Currently, under current payments, we have many primary care physicians are really undercompensated for the amount of work that they do, whereas our specialists tend to be well compensated. If the whole payment system doesn't change to reward primary care prevention and really creating health, we're not going to get anywhere, regardless of what the Supreme Court decides. So my question is, regardless of the Supreme Court, what is going to create changes in the payment mechanisms to reward health as opposed to X numbers of procedures treating illness?
That's a great question. I think probably the biggest thing, you're going to see a move across the country to move primary care practices to what's called patient-centered medical homes, which is going to be a strong support of their practice to allow physicians to care for a larger number of patients and create these things like the call centers, the nurse navigator, group visits, et cetera. With that, we're going to incent the physicians, especially primary care physicians, extra dollars per member per month in order to coordinate that kind of care coordination. So not only is Summa doing that with their primary, we're just getting ready to roll out a brand new reimbursement mechanism for our physicians, but you're seeing many of the insurance carriers throughout the the country, and I believe in this community, going to do the same. So you are starting to see more and more of this incentive to create patient-centered medical homes, which is going to be a stronger care network for the patients and improved outcomes around these chronic disease. And the beauty of what we've been able to do with the ACO is to allow them to have a share in the overall savings of the evidence-based best care, best quality, low cost, so that we actually create an incentive pool of savings that are generated from the right care, taking out that 30% that's unnecessary, and then giving back through these shared savings pools additional reimbursement to the physicians, both primary care significantly more, but specialists and the hospitals as well. Because in the end, if we do this correctly, it means less beds full, less procedures for our physician specialists, and hopefully a broader base of patients' access points to really support our primary care network.
Today at the City Club of Cleveland, we've been listening to a Friday forum featuring Thomas J. Strauss, President and CEO of Summa Health System. Thank you, Mr. Strauss. Thank you, ladies and gentlemen. This forum is now adjourned. Thank you, sir.
For information on upcoming speakers or for podcasts of the City Club, go to cityclub.org.